change those. So I just thought that was a good starting place.
Okay, so as we take comments, would you please identify yourself and then go ahead and make comments? And so, Warren, since you were the individual who developed this draft, if you would mind starting things off with your comments. This is Dr. Howe.
Okay. The draft there pretty much speaks to my opinion. What my feeling is that the three statutes regarding the practice of the various phases or the various philosophies of medicine, allopathic, osteopathic, and chiropractic, the statutes are outdated and antiquated, and the result is that it sets up places where situations where current practice begins legislature. The unfortunate outcome of that is that perfectly appropriate practice is being in some places not reimbursed and probably has the potential of being complained about and becoming the source of discipline and litigation, which I think is unfortunate. What I've tried to do in this draft, note the evolution of medical practice since the mid-'70s, when all three of these practice definitions were set up by the legislature, and try to at least set the stage for these to be looked at in a more contemporary fashion, so that practice can go on appropriately. I'll stop there and leave it to other people to take the draft apart.
John, as chair of the Osteopathic board, would you care to make a comment? Dr. Fenton, you make, okay.
Yeah, no, I turned the mic on. Basically, we discussed this at one of our recent board meetings, and there's a consensus of the DO board that we don't have any issue with the ability for allopathic physicians who are properly trained, and that's always a question of what we define as properly training, to do manipulative therapy. Now, the definition of osteopathic manipulation is very vague. It doesn't really specifically talk about what it does. It's referring to hands-on treatment of the patient, not just the spine. And the limitation that I see in the current rulings are this whole area of the manual spinal manipulation, which is defined as more chiropractic, but that's something the osteopathic physician does routinely. So I think as a consensus with our board, we feel that opening this up to appropriately trained physicians, allopathic or osteopathic certainly, is appropriate. I think it will provide better, more extensive care for patients, and particularly now with the boards and the training being combined, there's going to be a huge amount of overlap, and we need to get this coordinated so that people can learn if they so desire and practice in an appropriate way, and particularly, as Dr. Howe said, not leading it to any risk of confusion or cases against them.
Well, and also to be able to adequately regulate inappropriate care.
Absolutely.
So we have the chair of the chiropractic board. Would you care to comment?
Yes, I would. So in your new proposed draft interpretive statement, in the first paragraph, you are essentially allowing MDs to perform osteopathic manipulative therapy. It's our position that spinal manipulation is spinal manipulation, no matter whether it's chiropractic, osteopathy, allopathic, etc. And there are two express prohibitions in statute currently against MDs performing this procedure, both in RCW 1871.001 and 1825.005. So I don't think the Commission's position is that we don't think that an interpretive statement that goes against statute is appropriate. Secondly, we have concerns about adequate training, which was alluded to by the Osteopathic Commission, and we have concerns about patient safety and adequate training being in place before such procedures are allowable in the scope of the allopathic physicians. So those are our main concerns. And I just want to say, as a chiropractor who's trained and been through chiropractic college, is that spinal manipulation is not a procedure that's learned overnight. It takes hundreds and hundreds of hours of training. We've been through that. We've had clinical encounters, hundreds of clinical encounters before we were a graduate of chiropractic college. And as a practicing chiropractor, I'd have to say the first few years, I was still learning, and I was not proficient until I'd been in practice several years at a minimum. And so we have great concerns that whatever training is provided is adequate to perform this procedure safely. And so those are our concerns. I will pass the mic.
Okay, so at this point, I'd like to open it up to others who are present. Go ahead. Again, introduce yourself.
My name is Dr. Gary Baldwin. I'm the current president of the Washington State Chiropractic Association. And I think Dr. Follweather summed up our position perfectly. And I would like to say something just as a clinician. I've practiced for 35 years. And those 35 years, I've had an opportunity to know a lot of medical doctors in my community. I was a part of a group that actually worked with Shorewood Osteopathic Hospital back in the day when chiropractors were allowed to work with Shorewood Osteopathic Hospital. And it's my experience that every orthopedic surgeon I know, every osteopath I know, and I don't know everybody, nobody did manipulative therapy. They, first of all, overlooked it or discounted it, but nobody did it. Currently, I don't know any medical doctors. I do know some osteopaths that use it kind of as a modality, but not as a primary course of care. And so our concern at the Washington Chiropractic Association is truly safety, and that if you allow anybody to do it with a minimum amount of training, we're afraid that the public will receive a lesser service, that injuries could occur. And our concern is adequate training and people just using it as I learned it at a seminar on the weekend, as a modality that has for years been discounted, and now all of a sudden is being thought about. So that's just a clinical opinion and a perspective from a person that's been in the field for 35 years working with medical doctors in my community.
Thank you. Other comments?
I'm sorry, I was cut off, and this is Dr. Howe. I was cut off, so I missed almost all of that because I had to phone back in.
Oh, I'm sorry. Could we actually run through that again, both of you too? Thank you.
Sure, I'd be happy to make my comments again. Again, my name is David Follweather. I'm chair of the Chiropractic Quality Assurance Commission, and I'm here to comment on the proposed draft interpretive statement. The revised interpretive statement includes in the first paragraph the allowance of allopathic physicians to provide osteopathic manipulation, and it is our position that osteopathic manipulation is the same spinal manipulation that chiropractors provide, and so just changing the words to osteopathic doesn't really get around that. Also want to point out that it's the Chiropractic Quality Assurance Commission's position that an interpretive statement cannot go around statute and allow something that has express prohibitions in two statutes, RCW 18.25.005 and 18.71.011, where allopathic physicians are specifically prohibited from performing spinal manipulation. Then the other bulk of my comments had to do regarding patient safety and adequate training. So as a chiropractor whose main modality is spinal manipulation, I've had hundreds and hundreds of hours of classroom time in training on this, as well as many clinical encounters. And I also shared my perspective that even for the first maybe 5 or even 10 years of my practice, I was still learning and becoming more proficient to the point where I felt like the patient safety was adequate. So we have concerns that allopathic physicians, if they want to perform spinal manipulation, that they should have the adequate training to ensure patient safety. And it's not clear to me that that's been demonstrated here. I'll pass the mic.
Would you mind repeating your comments?
I think my comments, Dr. Gary Baldwin, I'm the president of the Washington State Chiropractic Association. I really think Dr. Follweather covered my comments completely. My other comment was the fact that I've been in practice 35 years, in the Kent community, Valley Orthopedics, now Pro Alliance, a substantial number of medical doctors in the area we're familiar with and have worked with over the years. And spinal manipulative therapy is just not part of anybody's practice. Chiropractors provide most of that, and our concern as part of the Washington State Chiropractic Association is safety for the public in terms of people that use spinal manipulative therapy as a modality rather than a primary course of their care. That's the end of my comment.
Okay,
and I'm
Alden, I'd just like to respond to that, and those comments are well taken, and actually I agree with them in the large sense. But what the situation we're faced with now is that routine examination procedures such as palpation, observation of range of motion, and things like that are being interpreted by some places, notably payers, as being the practice of chiropractic, and so they're not being reimbursed, and that we feel is wrong. A physician, any physician, be it an allopathic physician, an osteopathic physician, a chiropractor, should be able to perform physical examinations and procedures without fear of being criticized or being told that that's outside of the scope of practice. On the other hand, I and as our chiropractic colleagues have just stated, the vast majority of allopathic physicians would not even think about doing spinal manipulation a la that done by chiropractors. So I think that's kind of a phony straw man in this situation. I'll yield back.
Warren, one other thing that I would sort of like to say, and my background is in general surgery, folks, so I don't know what I'm talking about here, but I'm just going to throw it out because it's what I've heard. And that is that in sports medicine, that's a year fellowship in PM&R, which is a more than a year fellowship, that there is training that is provided by people that are have osteopathic degrees, and that the training in how to do these sorts of things and the ongoing training that people get or practice that people get in sports medicine and PM&R appears to involve some of the things that we're talking about. I don't quite know how to address that properly. I'm trying to convey something that I really don't know very much about. But my concern is that when we have had adequate training through extensive fellowships that are provided by competent individuals, that safe practice could occur. On the other hand, it does not appear to me that we would in any way be willing to allow things which would potentially jeopardize patient safety. So we would absolutely agree that patient safety has to be paramount, regardless of what else goes on.
This is Laurie Grassi with the Washington State Chiropractic Association. And as the person who negotiated with the physical therapist...
Can I interrupt just a second? We're having a lot of static. Is there anything that can be done about that?
No, it stopped. Good.
Those who can put yourself on mute, please.
Someone's doing their dishes.
Let's give it a try. Go ahead.
Okay. I'm Laurie Grassi with the Washington State Chiropractic Association, and I've been there 19 years now, and I'm the one that negotiated all of the 2 decades worth of arguing with the physical therapists and their ability to work towards spinal manipulation in their scope. And there are a few things that we all agreed on, and one of the key components of any agreement was a manipulation with a grade 5 thrust is just that, whether you put the word osteopath in front of it or chiropractor or medical physician or whatever. It is what it is. So terminology that's used in an interpretive statement or even in statute or arguments that try to differentiate a spinal manipulation by provider type is just declaring who's performing it, not the service, what the service is, because it is what it is. So the association clearly doesn't agree with an interpretive statement process. We challenge the time of a residency. How much time is there in training for spinal manipulation in a residency? Because the legislature set the training expectations for the primary profession that delivers manipulation, which is chiropractors. So we would like to see what an average residency program looks like in hours. Just learning it in a year is clearly unacceptable to us. And we would also agree with the commission that it does have to be changed at the legislature. And so for us, there's no gray area of can an MD or a DO can perform it, an MD cannot, clearly stated in 2 statutes. So we struggle with that dynamic. And if it's about payment and if it's about a payer not reimbursing for the right services, I mean, I can give you examples for decades of how chiropractors have been inappropriately paid. And even today, a large major payer is refusing an evaluation service, which is required in their statute that they perform, and demanding that not only they perform it, but that they don't get paid for it at all. And if they do, they might get one a year. So we have payers putting liability issues on all professions, not just medical doctors in this one example. So changing a scope of practice to give an entire profession the ability to perform something just to get paid isn't really the best approach, in our opinion. We'd rather work with you on payment issues and the appropriate CMTs, but to just capture spinal manipulation in that scope is inappropriate in our mind. I mean, when you had your November meeting, I stated on the record a study by Shakel that we find, it's an old study, so we find that it would probably be even a bigger number now, but 94% of all manipulation is performed by a chiropractor. Of the 6% that is not, comes more than 50% of the adverse events. So we have reason to be a little bit worried about it, or a lot worried about it. And for me, all 3 of the commissions that are involved here should be extremely concerned about that and public safety.
Thank you. Other comments?
Can I just make one more comment? So the fellowship program you were alluding to earlier for the PM&R program is a 1-year fellowship, is that correct?
I'm sorry, I don't know the answer to that.
Okay. Well, I just would argue.
I think 2 or 3.
Okay. Well, I would be curious to see how much of that.
I think it's 2 or 3, and I don't know for sure.
No.
No, this is PM&R.
So, I would argue that in a program that's, several thousand hours, how much of that, is training in manipulation and manipulative therapy. And again, our curriculum is 4 years, and we spend hundreds and hundreds of hours learning how to perform spinal manipulation safely. So I would be very curious to see if that program comes anywhere near that.
Can I make a comment? Just asking about this number of hours that you keep saying that chiropractors granted. Sorry, this is Diana Curie, Medical Commission. So I'm faculty in residency program for family medicine physicians that come from DO and MD schools. We combine them now. There's complete 100% cross-training and immersion. So distinguishing between who's a DO and an MD is not really a thing anymore in residency training. So I just want to ask about the issue of the number of hours that are required for training that I hear you saying is really important for what chiropractors do, and I completely agree with that. But I'm a little confused about the issue of like, so if you're a DO and you go off and do OMTs, that's fine by statute, and everybody agrees to that. But if you're an MD, you're not. And yet the number of hours of postgraduate training is not that different maybe in a person who's interested in that particular area of medicine, for example, people that are interested in sports medicine. So a 4-year degree as a DO gives you some exposure to OMT, but it's clearly not the same as your 4 years of chiropractor where that's all you do, because they learn a lot of other things too. So I would just say there's some inconsistency, some logical inconsistency there, because we've all agreed that DOs can perform OMT. Let me just go on and say that I think that the type of procedures that most DOs that go into sports medicine, who they do a 3-year residency in family medicine and then a 1 to 2 year fellowship in sports medicine, or somebody that goes into PM&R, they're getting training with professionals, with mentors, just like in every other area of medicine. So I teach family medicine. I'm an OBGYN. I teach them how to do OB. They clearly do not get as many hours of OB training as somebody who does a 4-year OB residency. And yet they are absolutely certified, licensed, and allowed to go out and safely practice OB to the limit of their comfort and their scope of practice and their training. And that is the way it is across the board in medicine right now. There is a lot of overlap in a lot of specialties. There's, I'll just move this argument one step further to say there is a great shortage of physicians out there, primary care physicians. There's a great number of patients that need care that only can see their primary care physician, particularly for common things like low back pain, that where the ability to do the evaluation, to do some hands-on manipulation, maybe not the 45 minutes that a chiropractor spends with them, but just a brief evaluation to at least get a diagnosis and determine what next steps need to be done, which we all hope are going to be to avoid surgery and do conservative management, because we know that's probably the better way to go in most cases. Cost to the system is less, cost to the patient is less, time out of work, all of that. There's lots of arguments there. So I'm failing to see where there's really a patient safety issue. I did hear you say an article, which I'm sorry I haven't read before, but current, say in the last 3 to 5 years, patient safety data on OMTs, or DOs doing OMT in their own practices, when their level of training is about the same as what an MD who maybe is in a residency with mostly DO faculty and are learning some certain kinds of skills, not the extent that a chiropractor would use, but the extent that would be appropriate in the evaluation of many common clinical conditions that we see in family medicine. So I think that we are doing a major disservice to the public by restricting some physicians from performing certain types of evaluations. It doesn't make sense to me, and I fail to see a patient safety issue. And I'd love to see some more sort of recent data on a DO who does some sort of evaluation and, is a family medicine residency trained DO who then does something that causes harm to the patient, because essentially that person is getting the same training that the MD is when you think about their residency training. So that's where I'm wondering what the issue is, or what the concern is, if you could address that. Thank you.
Well, I think you covered a broad aspect of issues. So the first I would say is, I don't believe
who's this speaking?
Laurie Grassi with the Chiropractic Association.
Oh, thanks,
I don't think that the WSCA would say that they ever wanted osteopaths to manipulate. It was a grandfathered thing that they probably couldn't take back at that time in the 70s. I was in elementary school, so I wasn't lobbying for them at the time, but I'm pretty aware of the historical debates between scopes of practice. So having physical exam and primary care available to people throughout the state, we totally agree on that. And you're talking to a profession that is pushed out of that. So we aren't able to facilitate the physical exam opportunities in the same manner by virtue of some payer issues and then also relationship issues. So I do see an opportunity for all three professions to build better working relationships within the scopes that they do have, allowing chiropractors to serve in a primary care portal of entry role in rural communities can move those spinal pain patients into a place where they're never going to get a drug, because chiropractors don't prescribe any drug ever. So I see a lot of opportunities to maybe move those inconsistencies aside, but to just capture a piece of a scope is clearly not where our membership is going to find a favorable position, at least not yet. There's been zero work done on it. We learned about it in November. So the profession is trying to understand the goal. Having it happen during session, admittedly, my phone is blowing up because of a bill I'm working on, and of course it would come up today. So it is challenging to have this. We would like to have a better dialogue with bigger goals of how do we all work through this together, and not in a, I don't think we're going to resolve it in 2 hours.
If I could address, I'm sorry, this is David Fulweiler, Chair of the Chiropractic Quality Assurance Commission. I want to address your concerns a little bit. So I am not an expert in osteopathy, but I believe in the 4-year program or 5-year program, however long it is, they cover manipulative therapy as part of that training, not just in the residency or fellowship program, whereas the allopathic schools do not, as far as I know. And then the second comment I wanted to make is that we have no problem with people doing evaluation and management services at all. It's just the performance of the manipulative therapy that is the concern that we have for patient safety. So not sure where the prohibitions are coming from, people being allowed to evaluate or make care decisions. It's just really the spinal manipulation or the manual manipulation that we're most worried about.
Yeah, this is Warren Howe again, and the problem with the interpretation is just that these conflicting statutes of scope of practice are being in some cases very narrowly interpreted and to the detriment of the patients who are involved. And that's what we seek to do here. We are not seeking in any way to suggest that spinal manipulation is going to become a huge part of anybody's other than a chiropractor's practice. I think that current osteopathic practice does OMT, yes, but doesn't put a great emphasis on major spinal manipulation. Allopathic practice doesn't put emphasis on that. That's the domain of the chiropractor. And I don't think that we're looking to change that. What we are looking to change is the way that the scope of practice of these three professions is looked at. Ultimately, we hope that the legislature will look at these scopes of practice and bring them more into conformance with what is actually current practice of these professions.
And then this is Alden Roberts, and I would just sort of like to throw out that for allopathic physicians, and I believe for osteopathic physicians, you can't practice after medical school. You have to do some form of a residency. So we basically believe that the entire field of internal medicine is done in 3 years. We believe the majority of training that is going to be used in a practice, regardless of what that practice is, comes in the residency. Medical school teaches you what you need to learn in order to be able to perform in a residency.
Yeah, hi, John Finch, Chair, Osteopathic Board. I would like to make a comment on that. Basically, through med school, osteopathic med school, from pretty much day one, we are exposed to manipulative therapy and practice it on our fellow students pretty much all through the 4 years. The residency program is going more towards their specific specialty, but and many residency programs right now, if you're going to neurosurgery, is certainly not going to focus a lot on manipulative therapy. So I feel a lot of my training personally was in school and certainly postgraduate as well. And certainly after 45 years, I think I've got it down pat. But I do manipulation as a regular part of my practice in family practice. It's another tool that I have to kind of add to my toolbox. But I do feel we get a lot of early training, again, starting at first-year medical students. Thank you.
Thanks, John. I appreciate that. Thank you.
This is Debbie Carlson with the Nursing Commission. I did put a thing out in the chat if you want to look at that. I knew this was in our law, but I just never, I don't think I've ever had any questions about it for RNs or ARNPs. But it does, we do have one of the laws in our law refers to the chiropractic law that RNs and ARNPs shall not be constructed as permitting the practice of chiropractic. My typing is terrible, sorry, in the chat. Chiropractic is defined in our law, including adjustment or manipulation of the articulation of the spine. So this is certainly something as you all go forward, I think, you know, we'll probably want to look at as well.
Thank you.
Mm-hmm.
Go ahead.
So just as a follow-up to this is Micah Matthews. Just as a follow-up to what Dr. Finch said, I just want to point out in reading the letter from Dr. Meyer from PNWU in the 5th paragraph where the bullets start, he is fairly specific that this is not about what's learned in medical school, but what's learned in residency. And he goes through and defines with I believe the accreditation standards that are from the AOA about what is taught in residencies, which are now combined, which includes a load of osteopathic manipulation therapy.
So this is Diana Curie. I had the opportunity to reach out to Dr. Mayer about this issue. I just want to bring it again back to modern day training, which just changed in the last couple of years, right? So the ACGME boards just merged so that all DOs and MDs go through the same match process. So this is a very recent development, and so I just want to acknowledge that. But for example, in my program, our faculty are 50-50 DOs and MDs, and what our residents are getting trained to do is a mix of that, obviously, or it includes OMT because that's what many of the faculty do. We have, for example, one sports medicine person who also trained in a place where his faculty were DOs, so he was trained to do OMT. He has a sports medicine practice in town where he sees kids and adults and everyone, and he does manipulation as part of his treatments. 2 of our residents spent 18 months going through the IRB to get a research project to perform a particular type of manipulation for kids, for school things. And I'm an OBGYN, I don't totally understand the details, but suffice it to say, after 18 months and getting this whole research project approved, which would have contributed significantly to, I think, the furthering of treatment and evaluation and sort of medicine in general, it turned out nobody realized that because the sports medicine doc, who was the PI, is an MD, it got disallowed. So after all of this work, and both of the residents, I think, were maybe DOs, or maybe one was MD and one was DO. But again, this drives home the point that it's virtually impossible these days now to separate these two specialties. I mean, allopathic and osteopathic have just completely merged. And so anything that is in statute or in interpretive rules, and I'm new to the commission, so I'm still learning this stuff, that hampers our ability to give good training and good experiences and provide research opportunities, et cetera, for our young doctors coming through training just feels like a barrier to care, to providing good training and more opportunities for patient care and access for patients. And I don't think in any way, shape, or form that what we're training our young doctors to do is causing a patient safety problem. That just doesn't ring true at all, because I train them to do all kinds of things. And, it doesn't take 1,000 hours. Well, you could argue it takes 1,000 hours to learn to do a good delivery, but actually it doesn't, turns out, so there's a real need for us to acknowledge the changes that have occurred in medical education and incorporate that into modern practice.
This is Alden. Micah, do you know what other states do? What exists elsewhere besides here? Or does anybody know? It doesn't have to just be Micah.
I will defer to other people in the room because I've not researched that.
I can't address the states issue. This is Laurie Grassi again with the WSCA. And Dr. Curie, I appreciate your comments. The issue I have is chiropractors can't even do what you're talking about. They're trained in it too. And they're not even allowed to treat those kids because the school districts get involved and the WIAA gets involved. So we are here to help, and we would love to be able to help. So there's a lot of non-modernization going on. It's not the chiropractor's fault that your two professions merged your training. And we disagree with Dr. Meyer's letter where he states there's nothing in state law that prohibits MDs from performing OMT. Take out the O, it's MT, and I beg to argue, I find 2 statutes that are very clear that he can't do it. And I guess I'm gonna put this on the record because at the meeting in November, I am not a chiropractor, but I was personally offended by the lackadaisical comments that were made of medical doctors on your commission admitting they were doing it. And one person said, and I'm taking a stand. And another person said they're doing it, and too bad. I mean, I think that's a disregard of statute, first of all, and not one lawyer in the room said, you know, you probably shouldn't say that on the record. You're supposed to be following your law, and you're admitting you're breaking your law. So that's where we're at. You know, it's a tough place to be, wanting to work together, but you're looking at a profession that the medical community, whether it includes osteopaths or not, has been oppressed and stepped on for 50 plus years. So now we're supposed to just step aside and let you change a scope or change a statute when some people don't even believe that the statute disallows an MD from performing manipulation when it's quite clear that it is. So there's a lot to be fleshed out in the dynamic that's occurring, and it's not the chiropractic community's fault that the education has gone that direction. So building relationships with all 3 of the physician level professions is probably a better place to start in understanding why we're concerned about safety, because the headline isn't going to read, a medical doctor performs manipulation on patient in Tumwater without training and hurts them. It's going to be chiropractic hurts patient. That's it. So we have a reason to be careful about the approach and defensive to it, not wanting to be defensive, but appropriately careful.
And Dr. Curie, I'd like to add to that. Part of our education when we were in our clinical practice was understanding patient problems so that we knew they were appropriate to treat with chiropractic and that they weren't medical issues. And so chiropractors are taught prostate exams and gynecological exams, and we listen to heart sounds. Now, if a chiropractor came up to me and said, I really would like to do chiropractic cardiology and make a diagnosis based on that training, it would really scare me a little bit because it's what we learned to be able to refer, not learn to be able to practice. Very different. And I know you're new to working with chiropractors, but when you kind of suggest somebody goes in a residency, takes a couple of classes, and yes, it's not many hours, that how could it be possible to be that difficult? That really discounts what I've done for a really long period of time. I don't think chiropractors or brain surgeons, don't even claim to be that. But I do think that your perspective about what we do is short of what we do. And I can say as the president of the Washington Chiropractic Association, if I were to go to my membership and said, this is how Dr. Curie thinks, you'd upset a lot of people. And I wouldn't do that because I don't want to build that kind of relationship. But you've really discounted what we do to be, we were in residency, I taught a few classes, how can it be a problem? That bothers me.
I appreciate that feedback, and I obviously didn't, I want to say that I didn't intend to come across that way.
And I'm not offended by it.
I feel like what we're asking for our residents that are being trained to do some of the brief things that they do. This is a sort of a 5-minute evaluation, maybe little manipulation thing.
See, right there, that
let me
bothers
just say,
me, Dr.
so
Curie.
is there a way, let me finish. Believe me, I go to chiropractors all the time. I know what the difference is, okay? Or at least I've experienced it myself. Let me just say that, back up, is there a way to carve out the piece of this that is what is realistically done in the context of a sports medicine evaluation with a, you know, it's a very different thing than like global chiropractic exams. And most sports medicine docs, when they want a patient to get more treatment, they do refer them. But they do certain things, and I did invite our sports medicine guy, I'm sorry he's not here, I'm trying to speak for him and I'm not doing a very good job. There are certain things that are done in the context of an evaluation that is not what I think of, at least the layperson view of what chiropractors do. It's just in the context of what he's doing in his sports medicine evaluation and deciding whether or not someone should have surgery, et cetera. So is there a way to carve that out, I guess is what I'm asking, because that feels like a very different type of exam and treatment than what you're talking about.
Briefly, I'll say this, is Dr. Moreau was, I think at the last Olympics, was a chiropractor that was the head of the Olympic, U.S. Olympic team. He was the medical director, chiropractor medical director. And what Dr. Moreau said is that when we're evaluating an athlete, they get exactly what they need. They've got the best orthopedic surgeons in the country. They've got the best physical therapists, the best athletic trainers, the best chiropractors. My point would be that maybe the sport physicians, just like on the Seattle Seahawks, have individual specialties and go in that direction. Because I think any one of those practitioners, the athletic trainer, the physical therapist, the chiropractor, and the orthopedic surgeon that works with the Seahawks or the Olympics has a specialty and doesn't really want anybody doing what they do, but will work with the group to provide the best care. I don't think somebody doing it all is the appropriate thing.
I think too, this is Laurie Grassi again, I think that, I mean, it's an interesting question. Is there a way to carve this out? I don't know. I think we probably don't have all of the right people in the room, because if there are sports med folks for all three professions, might need to sit down and talk about it. I do know that, you know, when Dr. Baldwin made his reference about cardiology and things, the younger generation, sorry, I don't mean to call out age,
okay.
They probably want us to modernize some things in the chiropractic scope as well. And again, it all sits at the legislature. So each one of us, in terms of the three professions, has to go to that body and talk to those people about what is appropriate to be in a particular scope of practice. We're all living, well, aside from the osteopaths in this case, we all have a scope of practice that we have to work under. In Washington, it appears that the osteopathic scope is the broadest, because there is no prohibition on manipulation where there is in the medical scope. So probably in other states, the physician scope is the biggest, the medical physician scope. So it seems like we have at least till next session, maybe to pull some of these folks together to talk about what really is different. Because I don't feel, I mean, I grabbed happened to be the president, one person that was available on a Friday for me to bring to this meeting today, and would really rather it be the educated practitioners of multi-generational, younger and older, to talk about risk and liability and training and those things. And to Dr. Curie's point is including the sports folks of all three sides to see what really is the problem. Because if it's just a payment issue, then I think we're doing a whole lot of work for and creating a lot of angst over not getting paid for something when chiropractors don't get paid for things all the time, like forever.
Thank you. And the one thing, this is Alden Roberts, and the one thing I would sort of like to remind folks is that in medical school, we also learn about cardiology and neurosurgery and all this other stuff, and we don't practice it either when we get out and practice. So I understand what you're saying, but if a chiropractor were to say, you know, I want to go into cardiology, they would need additional training, just like a medical student coming out of, and who says, I want to go into cardiology, would need additional training too.
Yeah, this is Warren Howe, and just to reorient things, we seem to have gotten off into the weeds here. The meat of this proposed interpretive statement is the last sentence of the next to the last paragraph, which says that the Commission believes that a licensed allopathic physician and surgeon and a licensed osteopathic physician and surgeon or chiropractor, we put that in parentheses, should be entitled to exercise any skills and techniques in the examination and treatment of patients for which the physician has been appropriately trained and which the physician can perform safely with competence. That is the way the medical commission is going to evaluate any complaint made about a physician's activity. The interpretive statement then goes on to ask the legislature to look at these three very antiquated scope of practice statements and try to modify those. But in the interim, and it's going to take a long time to get that done with a lot of meetings and lobbying and everything else, in the interim, I think we have to base what we are judging on the training and abilities of the particular practitioner and not on some outdated scope of practice requirement.
Hi, this is Jenny. Can I give some input?
Yes, thank you.
Can you hear me?
Yes, thank you.
Yeah, my name is Jenny Lynn. I am a coding specialist and consultant. I've worked with various coding and auditing positions for the last 20 plus years. I was an auditor at LNI, and I was interpreting the RCWs for different auditing functions. And now I work for Providence, and we've been working very closely with our sports medicine providers on this exact issue. And I just have a couple things I want to add to the discussion. One, the RCW in question talks about adjustment and manipulation as a chiropractic function. But in the last note in that definition, it says that other physicians are not, I had it up, are still able to do these functions except the adjustment of the spine. So it doesn't preclude manipulation. And so when we talk about the OMT services, the manipulation, the spinal manipulation, our sports medicine director is very strong, has a very strong stance on spinal manipulation with that are covered by the OMT services are very different than the chiropractic adjustments being done. And a couple of things, let's see, I want to note. One, that there is a difference between the spinal manipulation and the spinal adjustments. And so with your language that you have in this draft proposal, it fits, and I feel it does not go against the RCW because it is allowing the manipulation, but it is not allowing an adjustment, which would preclude the chiropractic adjustments. I also want to point out that CPT, which are codes published by the AMA, have a very clear definition between chiropractic adjustment and spinal the OMT. So those services are separate. And then I also wanted to share that I was in contact with Medicare regarding the OMT services. And a few minutes ago, somebody asked what other states do, and we are one of the only states that do not allow spinal manipulation by specially trained MDs. Medicare in 2018 just recognized the sports medicine specialty as its own specialty. They did not recognize it before 2018. So this draft language would include the sports medicine providers, because right now, as it stands, it is excluding those sports medicine providers who have been specially trained extensively to provide the OMT service. When I contacted Medicare on their federal rules regarding OMT reimbursement for MDs, they told me that yes, they will reimburse MDs who are specially trained, and if they had a question, they would just ask for the training, documentation for those providers in question. So I just wanted to share all that information that is in support of this draft language, from a different perspective.
Thank you.
Jenny, are you a lawyer?
I am not. I'm not a lawyer.
Thank you.
But I have several certifications, and I have been an auditor and worked with several lawyers on different coding and documentation issues.
Hi, Jenny, this is Diana Curie again. Can you tell us what the CPT codes are that fall under spinal manipulation versus spinal adjustment?
Adjustment. Yep, it's 98925 through 98929 are the OMT codes. And then the adjustment codes are
98940 through 98943. And there's precedence on
yes.
those codes as well, because there are some statutes recently passed on payment of those issues. So there's arguments about definitions of those that are on the record.
But it sounds like, this is what I was trying to get at, again, based on my discussions with sports medicine docs, again, not being one, but where there are certain things that they do that are actually not considered spinal adjustment, right? And there are certain things chiropractors do that are spinal adjustment. Thus,
Correct.
It is recognized in the CPT codes that there's a difference.
Yes.
That's what I meant by the carve out. Thank you. Thank you, Jenny, for that.
There is clear understanding, though, that the manipulation is an adjustment, is a grade 5 thrust. So that is on the record as well.
Can I ask a question of the Assistant Attorney General?
Yeah, again.
Oh, sorry. Yeah, David Fulweiler, Chair of the Chiropractic Quality Assurance Commission. I'd like to ask the AAG a question. Is it possible in this interpretive statement to say that including osteopathic manipulative therapy is allowable for allopaths and have that run in contradiction to the statute that exists?
So excuse me. So in general, an interpretive statement does not override a statute. A statute is controlling, and an interpretive statement is advisory only. So the statute would trump any interpretive statement. So if they are in conflict, the statute controls.
Yeah, this
How would that be decided?
is Warren Howe again, and the proposed interpretive statement actually carves out and says that the commission is not going to look kindly on treatment techniques that would be considered the practice of chiropractic, or practice that would cause the physician who is doing it to be viewed as or designated as practicing chiropractic. So I believe that this interpretive statement takes very due cognizance of the existing statutes.
So Dr. Roberts asked me the question on how
How would it be decided?
How would it be decided? So there would have to be.
How would it come into conflict?
So if there were some so let's say in discipline, and I'm just trying to think if there was there wouldn't be an unlicensed practice because that would come to you as beyond scope, and you would determine whether or not a MD is practicing beyond scope. If somehow this were challenged in court, the court would look at whether or not these are in conflict and could void out or nullify an interpretive statement. So any argument that they conflict, is won by the statute. Whether or not they do conflict is the question.
Right. And that would be decided by a challenge.
Correct.
Or it could be, if the commission were to move forward, we could request a rulemaking petition. Secondly, we could go to the assistant or the AG's office and request a formal AG opinion. And then there's the legislative battle.
Might point out that those determinations are any decision of the commission on any matter is subject to appeal and interpretation by the courts. So that really doesn't change anything.
Other comments?
This is Dr. Rosemarie Colombini. I'm on the call. I'm a family practice physician who's an osteopathic physician, and I've been in practice over 20 years. I just wanted to clarify for the record and for the commission. I know it's difficult sometimes for lay people to understand, the difference between a physician, a chiropractor, what's an osteopathic physician. In my training, I also have had hundreds and hundreds of hours of hands-on manipulation, not even counting before, residency. So what we don't want to do is limit the scope of physicians, and we want to move forward with the future of what's best for patients. And I would agree patient safety is a primary concern, but there's no evidence presented that there's anything about patient safety being at risk. I've heard, some things mentioned by our colleagues, and I think it'd be really important to stick to things that are evidence-based. And I think that chiropractic spinal manipulation plays a huge role. I have friends that are chiropractors. I have actually a friend who went to medical school with me who had been a chiropractor that then applied and went to osteopathic medical school to become a physician. And it's interesting, there's differences, but everybody has a role and we're all here to help the patient. And it might be helpful for the commission to get more information from the federal level, especially about the ACGME combination, where residency training combined. It is new in the past few years. We all have questions, but it's being done successfully. It looks like a lot of the other states haven't had the same glitch. Whatever our prior restrictions, 20 or 30 years ago that are making this difficult might be revisited. Perhaps everybody could work together. And listening to the interpretive statement, which I read before, and then hearing the draft again today, I would just suggest, me just as a local concerned citizen, I'm in favor of the interpretive statement. I don't think we want to limit scope on any physicians, and there are restrictions, of course, on our licenses, but they're already in place. Anyway, that's just my bit. I like that everybody's working together, but I am a little concerned. There's been a few statements by our chiropractic friends, which I don't think have been factual. It's just, something that needs to not be emotional, just needs to be everybody working together and moving forward. For example, if I do manipulation on a patient and I'm seeing that patient for her pap smear and she has low back pain, I might be evaluating her pelvis and noticing that there's a rotation and doing some techniques, but it's not going to show up on anything. So I would question this data about 94% of manipulation in our state being performed by a chiropractor. It's perhaps not factual. I don't have data to tell you, what percent of providers are chiropractors and how many physicians of each type are in our state. But the whole point is we're all working together. We all want to train these new doctors coming out. We want to promote Washington State as a great place to practice. I am a little concerned about restrictions that would make us lose residency programs. We all know that we have more primary care doctors if we train them in our state. So that was my biggest thing I wanted to point out. And I applaud you all for working together, and this is definitely a difficult but very important issue. Thank you so much.
Thank you. Yes, sir.
Yes, this is Bob Nikoloff. I'm the Executive Director of the Chiropractic Commission. I'm speaking for the staff of the commission, and I don't think Dr. Fulweiler will disagree with me, but our staff has a long-standing positive relationship with the Medical Commission, Osteopathic Commission staff. We are ready, able, and willing to assist with any research or discussions or brainstorming that would be helpful. Sounds like there's lots of questions unanswered at this point. So I just want to put that out there that it could be a very positive process, not only for this resolution of this topic, but bigger issues as well.
Yeah, Warren Howe, that was very refreshing. Thank you for that comment. I'm a sports physician, and I've been a sports physician for many years. And the impression that this change and allopathic physicians being taught osteopathic techniques is a recent thing is really not true. I've been going to sports medicine meetings for approaching now 50 years, and for at least 40 of those years, my osteopathic colleagues have been very freely giving instruction to us allopaths about the use of manipulative techniques for certain things, and I've gradually adopted many of those into practice. So it's not an entirely recent thing, but there is this amalgamation that's going on, this blurring of distinctions, and I think we eventually that needs to be addressed by the legislature. But in the meantime, I think we can look at reality and try to benefit patient care and maintain patient safety. Thanks.
Thank you.
Dr. Brown, are you on the phone?
I am.
You have the floor. This is Diana Curry, if anybody else is okay with that. Yeah, this is David Brown. He's a sports medicine doctor I was alluding to earlier. You're welcome to speak. You're on speakerphone now.
Okay, I'm sorry. I had an interview I had to conduct for an occupational medicine physician, so that ran late. So I apologize. I wasn't able to get there in person. I guess I'm a little bit handicapped by the fact that I haven't heard the previous discussion. But just from my perspective and by way of background, you may have already discussed this, but I'm a MD, and I trained in the military, and I was very fortunate at my time prior to and during my sports medicine fellowship to train with some very excellent osteopaths. And ultimately, I was able to get privileged to do osteopathic manipulation while I was in the Army. And so I did that for a period of over 20 years. So since 1998, I've been doing OMT, and it was something I wanted to continue when I got out, which I actually did, not knowing that our State Practice Act was amended in 2004 to say that we would not be allowed to do manipulation of the spine by hand. And so it's, as I mentioned, it's something I've been doing for a long period of time. I've been doing it very safely. I've never had a complication of my treatments on patients.
Oh, no.
Uh-oh. Oh, no.
But we'll see if we can get him to call back in. He unfortunately got disconnected.
Seems
So
to be happening
I think
a lot.
it's important to clarify that it was our practice that it hasn't been changed in 2004. So the prohibitions have been there since the 70s. So he's incorrect in that regard.
Right.
Well, do you want to comment on the other part while we're waiting for him to comment?
Yeah, so I have a question about the 3 different statutes that are on this document that we're looking at. So I understand that in subsection 4 of 1871, it says that the allopath can do all this, provided that there shall not engage in the practice of chiropractic as defined in 1825. Okay, so then I go to 1825, and in paragraph 2, it's the treatment also includes heat, cold, water, exercise, massage, trigger point therapy, dietary advice, nutritional supplementation, normal regimen and rehabilitation of the patient, first aid, counseling on hygiene, sanitation, and preventative measures. So I read this, and to be honest, just again, I know I'm new to this, but I was really confused because I'm like, well, that's something that we all do. So I'm reading 1871 and it's saying I can't do what's in 1825, and then I read 1825 and I go, well, that's everything. I mean, that's like a lot. So I'm already feeling like I don't understand these statutes. They feel very inconsistent already. So help me, I guess, understand, Heather, how to understand that.
Yeah, this is Heather. So your statute, which is 1871, defines the practice of medicine, has that restriction on performing chiropractic, which refers you to the 005, right? 005 goes through all the different things that a chiropractor can do. But if you go to section 5 of that statute, that's, I think, the most important part for this discussion. It talks about nothing in this chapter prohibits or restricts a healthcare professional defined in 18.120.020. All the different licensed healthcare providers, including MDs, DOs, are included in that. From performing any functions or procedures the practitioner is licensed or permitted to perform. So that gets you, yes, you can do the heat, that sort of thing, but it does then go on to say, but you are prohibited from performing the adjustment by hand of any articulation of the spine. And that's at the very end of 5. Yes. So a lot of this, dietary advice, cold water, exercise, all of that, in subsection 5, it's telling you, okay, MDs can do it. A dietitian can give, obviously, massage therapists can provide massage. So even though those are part of chiropractic and chiropractors can do those things, other professions can as well.
Why does the chiropractor statute have so many different modalities in it, like enumerated explicitly, and the osteopath and allopath doesn't really have like all of it? I don't understand. It seems like a difference in detail.
Yeah, and I think, so the Medical Practice Act and the osteopathic, so they used to be combined, but those are very old. They, came around with like territorial laws. They've been there where basically a medical
1890s
physician couldn't do just about anything, right? But then the chiropractic statute is much newer. It came about in, I think, the 70s, if I know.
This is Laurie Grassi. It's originally licensed in 1919 and modified in the 70s.
Okay.
And my understanding from historical reference of why it's called out is because the medical profession at the time wanted to declare what the chiropractor could do instead of having it be as broad or generic. We all agree that they need to be modernized. We do agree on that.
And I will say that a lot of other healthcare professions, except physicians, medical MDs and DOs, are pretty specific about what they can do because they're sort of carved out of the Medical Practice Act, which allow a very, very broad scope.
Thank you so much.
Yes.
Dr. Brown, are you back on?
I am.
Sorry that you got cut off. Could we try again?
Not sure where in my soap spot speech I got cut off.
David, you were about to say something about problems with patient safety or data regarding patient safety, either in your own practice or generally. Something in that line is where you got cut off.
Okay. It's like I'm walking outside because I got cut off because I was talking in the clinic. I got to put my coat on. So what I think where I was at is talking about having, trained with and become credentialed in the military setting to do manipulation, which I've been doing for over 20 years, and never with any patient complication, let alone any patient complaint about it. And so you know, it was very disturbing to me when once it was discovered that based on the State Practice Act that I'm not allowed to do what I've been qualified to perform in the past. And from my perspective, I provide a great service for my patients, and many have excellent results, and I don't feel like my practice infringes at all upon what chiropractors can do in their practice. In fact, I refer very, very broadly here locally to various chiropractic groups from my sports medicine clinic. So it's not that I feel like I'm infringing on the number of patients that they can take care of, not decreasing their workload, but if I'm enabled to practice the skills that I'm trained to provide, I think I can provide good care for my patients that I do follow and treat within my clinic. And then I guess the broader implication for, you know, our organization and for graduate medical education in particular is I have resident physicians rotating with me, many of whom are graduates of DO programs who in the past I've been able to supervise doing osteopathic treatments in clinic, but without me being able to practice it, I'm no longer able to supervise them. So that actually ends up infringing upon their practice of medicine and also decreasing the learning experience within sports medicine.
Thank you, Dr. Brown. Other comments?
This is Laurie Grassi. I'll send you, Amelia, the study, the Shakel study that I cited.
Thank you. Anyone else? Amelia?
I have a comment.
Yes, sir.
David Fulweiler, Chair of the Chiropractic Quality Assurance Commission. I do think that there is an opportunity through this process to work collaboratively on the practice acts. I mean, if the practice acts are going to be modified, I think there's an opportunity for all of us to work together. There are many of my colleagues who feel a little hamstrung by the current chiropractic scope of practice and would welcome an opportunity to get that to more accurately align with what is taught in school these days. So I think in some ways our professions are alike that way, that you're feeling hamstrung, we're feeling hamstrung. So I think there may be some way that we can work collaboratively together to get what we want.
Thank you. That would be ideal.
That sounds good.
Yeah, I think in this day and age, this is Dr. Brown. In this day and age, you know, where, you know, there's great challenges for access to care in general and for modes of care that are effective in treating patients without going down a pathway that leads to, you know, chronic pain management, especially with narcotics. I mean, I think whatever we can do to work collectively, even though, you know, obviously our different practices overlap in many areas, but where we can come together and work as a group and all practice to the very top of our skill set, I think that's the key thing that should come out of this.
Thank you.
So thank you everyone for participating. Our plan is to have another meeting probably on April the 8th, which is the day prior to our April commission meeting. And you can, of course, send any comments or questions to me at the email address that's on the screen, and I can include those. Please be aware that anything you send me is part of the public record, and so they will be posted to our website and provided at the meeting. There will be a call-in option for that as well, and our meeting will be in Tumwater. It will likely be in this building again.
And as Chair of the Commission, I would like to thank everyone who has participated. Thank you very much for coming here. This has been very productive, and we appreciate the help here. Thank you.
Thank you all.
Thank you.
Thank you.
Thank you.